Welcome to the Possibility Action Network podcast. I'm your host, Stephen Middleton, aka Possibility Man. We're committed to bringing you guests who strive to better people's lives and serve as a force for good in the world. Dr. Theodore Henderson's passion for psychiatry and neuroscience is reflected in his treatment of mental disorders. His unparalleled expertise in the neuroplasticity of the brain is the cornerstone of his work. His research confirms that conditions like anxiety, depression, and brain injury can be resolved with proper treatments. Dr. Henderson founded Neuro-Luminance to bring these revolutionary treatments to the world. His book, Brighter Days Ahead, offers readers a chance to become acquainted with his revolutionary techniques from the comfort of their homes. Dr. Theodore Henderson, welcome to the show today.
Thank you so much for having me, Stephen. It's a great honor to be on your podcast.
Yeah, look, I'm excited to have this conversation with you. But first, a reminder to our listeners and our viewers, follow, like, and share this podcast. Wherever you find it, your support matters and is appreciated. Hey, Dr. Henderson, look, I've been looking forward to talking to you, as I've said before, but I want to get to know you better, and I'm sure that the audience is just curious about your background. I mean, you have a medical doctorate, and you also have a PhD degree. My first question, were you dreaming about these careers when you were, let's say, a ninth grader in high school?
Quite the opposite. In high school, I was a musician. I played the reed, sax, clarinet, whatever had a reed. And the music was everything to me. I mean, I spent hours practicing and rehearsing. I went to college as a music major and, would put in 16 hours a day playing. Along the way, I also figured out that, my chances of actually being successful were very, very, very small. I mean, if you think about a symphony orchestra, there's 2 clarinet players. That means in the US, there's about 100 seats for symphony orchestra clarinet players. And most of those turn over with death. They don't turn over very frequently.
Mm-hmm.
So I started to explore science. And long story short, I ended up going to medical school. And my PhD is in neurobiology, and specifically what I was studying was how the brain developed and how the chemicals that regulate neuroplasticity regulated development.
Mm-hmm.
So it was quite natural that I ended up in psychiatry and neuroimaging and looking at how the brain can reorganize itself after any kind of damage.
Yeah. Now, you mentioned that while you were in college, you began to look into science. What pointed you? Was it a teacher? Was it something you read? What pointed you to science?
Well, surprisingly, I managed to escape from high school with almost no science whatsoever. And so I really had no idea. And I hadn't even tapped into that part of my brain. And for me, science just came alive. It was like a whole new world opened up to me that I hadn't even known existed.
Mm-hmm. Okay. And so, in medical school, I mean, like, there's so many different areas to choose from to specialize in, but you chose to specialize in psychiatry. What prompted you to do that?
Well, there are several factors that played into this. I really went to medical school to be a surgeon. And my PhD work, there was a lot of surgery in what I was doing and the research that I did because I was working on looking at the brain before birth. So I was working on doing surgery on fetal rats before they're born. So microsurgery under the microscope. I got a lot of experience with that. And along the way, I realized that the best surgeon on the planet, and my neurosurgeon is one of those guys. What they do is they do the same thing, the same way, exactly, and they do it that exact way every single time. Now, for me, as a recipient of that surgery, that's wonderful. But as a surgeon, that's sort of the definition of boredom for me, doing the same thing exactly the same way over and over again. So with my, at the point I graduated from medical school, I was already had 2 NIH grants. So I was already doing research. And I was trying to figure out, how do I do medicine and research? So I actually started out in radiology, because you read a stack of films, you get to the bottom of the stack of films, and you go back to the research lab. Okay. Well, it didn't quite work out that way in practice, but that's where I started. And it, for me, I already knew the brain, so neuroanatomy was easy, neuroradiology was easy, but it was also, again, somewhat boring. And I needed to be challenged. And that's what led me to pick psychiatry. The other piece of that puzzle was that I was in St. Louis. I was at St. Louis University and then Washington University School of Medicine. And I had started a nonprofit in St. Louis that was teaching kids about good touch, bad touch. In other words, it was a child sexual abuse prevention program. And I trained up medical students to go into the classroom and teach kids, because there was no program, there was no education on child sexual abuse in the entire medical school curriculum. And that's actually true of about 75% of all medical schools in this country. So and it was true then, and it's true today. And so I started that program to sort of, address that educational gap, but also to help the community, and ran that program for 10 years. So that aspect of child psychiatry was already a part of my life. And so it was not surprising. I ended up getting a MD and a board certified psychiatrist, and I did a fellowship in child psychiatry. Not surprising.
Yeah,
with those
I tell
combinations.
It's challenge. Medical school, any graduate program, but medical school in particular, is challenging enough. But you got a medical degree plus a PhD. What's driving you? You must be a driven individual.
You could say that, yes.
Okay, yeah. But in addition to this, I've noticed that, you are a prolific writer and researcher. Just to put it in the record, I saw, and maybe more than this now, more than 70 scholarly articles.
That's correct.
You've written books. And as I understand it, are there also patents to your credit?
Yeah, there are 5 patents at this point.
Wow, that's amazing. Okay, so look, you're working with people, you're dealing with the psychiatric disorders and the like, but sometimes scientists or practitioners may do this work with little personal understanding with adversity. How about you?
I talk about that a little bit in my book. I don't go into great detail, and I won't here, but I grew up on the wrong side of the tracks, and I grew up in a very violent household. We'll leave it at that.
Yeah.
So, on the child adversity scale, which is a questionnaire that people can fill out, and, I score pretty high. And so does that play a role in who and what I am? In a sense, because it was always, I need to make this accomplishment. I need to accomplish this, and then I can stop. And somewhere along the way, I decided, okay, I don't have to stop anymore. I can just keep doing it.
Okay, so do you think, you mentioned adverse childhood, do you think that the ACE study, the adverse childhood experience study, is valid? Do you think that's a good predictor of what a child may become as an adult?
There are so many factors that play into that. Having, let's just take child abuse. Being a victim of, we'll stick with just physical child abuse, keep it really simple here. Having been exposed to physical child abuse as a child, 2 paths can happen. One is that you adopt that. You adopt that behavior, and that becomes part of your behavior repertoire. And then you become someone who is abusive later on, either to your significant other or to your children in your life. Or you can make the other choice. You can say, wow, that is so antithetical to my values. That's so opposite of where I want to be in my life. I'm never going to do something like that. That would have been the choice that I made, is that violence and abusive behavior has no place in an ethical modern society, and certainly not in a family.
Yeah. Yeah. I guess ultimately we do have the power if we can figure it out early, right? A kid who was born in a poor family, no educational opportunities whatsoever, could still earn a PhD because the kid we ultimately have those choices. But let's look at, you're a psychiatrist, and I've talked to some psychiatrists in the past, and there are some common mental health conditions. I think that's global. And I just want to explore some of them, trying to figure out where these things come from. And I want to talk with you first about chronic stress. What is it, and its impact on a human being living with it for a period of time? Share with us about that.
Yeah, so chronic stress or if that gets to the point of causing PTSD or causing depression,
Mm.
there are a number of factors that go into that. So first off is genetics.
Mm.
We don't know what the gene of depression is. There's probably multiple genes, but somewhere among that array of genes is a susceptibility gene. So think about 9/11,
Mm.
and they looked at the population of New York after 9/11. Now, even if you did not know so many people knew someone, had a friend, had a family member, had an acquaintance who lost their lives in the World Trade Center disasters. But everybody in the city smelled the burning.
Mm-hmm.
Everybody was exposed to that traumatic smell linked to the visions of the harm happening to these people and the buildings falling. But not everybody developed stress or anxiety or depression or PTSD.
Mm.
Even among the people who lost a family member, not everybody developed PTSD. There is something protective. Now, we have a little clues to that because one of the things they did is they started giving people propranolol, a beta blocker. So it was blocking the body's response to adrenaline. And that helped some patients who were already, stressed and showing up at clinics to not go on to have PTSD. So a little tiny hint that something about the adrenaline system may be important in protecting against stress turning into depression or PTSD. But, we had to understand what depression really is.
Mm.
A while back, you had a psychiatrist on who's out in Washington, D.C., and he was talking about the party line. Oh, well, stress causes your serotonin levels to go down, and therefore you need to take a serotonin reuptake inhibitor to raise the serotonin levels. Well, that's actually been disproven.
Mm-hmm.
I mean, serotonin has been shown to have nothing to do with depression.
Mm-hmm.
And the fact that SSRIs work on depression is a happy accident. What
Wow.
really SSRIs do is they very weakly, very poorly, very slightly, if you're really lucky and you've got the right genes and Mars is in retrograde in Capricorn, then you will get an antidepressant benefit from an SSRI.
Mm-hmm. Okay.
But it takes 6 weeks.
Okay.
Now,
Okay. So let's stay with this a little bit. And I want
okay.
to ask the kind of chicken or the egg kind of question. So you've mentioned we talk about chronic stress, but you've also mentioned depression.
Mhm.
So which comes first? I mean, is it the chronic stress that may produce depression, or is it the depression which may produce chronic stress?
Well, a fascinating question. I think I think both are possible. Again, you've got genetic vulnerability, and more typically, what you hear is that people experiencing chronic stress, chronic losses, job problems, whatever, and that leads to a mood change.
Mhm.
Now, what is going on at the level of the brain, though, is that chronic stress leads to degeneration of synapses and dendrites and the breakdown of circuits. So literally, depression has been shown to be a degenerative change. PTSD is a degenerative change. The frontal cortex gets thinner, the hippocampus gets smaller. In fact, that's been known since I was in medical school.
Yeah. Okay. Now, you've talked about, and I've heard you talk, you probably write about it as well, about chemical imbalance in the brain. You're not a big fan of that.
Mhm.
But I want to shift this to anxiety just a little bit because, I've read that people who suffer anxiety just see it come out of the blue. So I'm wondering, where is that coming from? Is that connected to a chemical imbalance or would it be connected to something else?
Mhm. Yeah, so the other thing to keep in mind is there are other things that affect the brain. So inflammation can lead to depression, anxiety, cognitive problems. The work of Bredesen looking at how the disruption of the insulin receptors leads to dementia,
Hmm.
and by correcting that, he has patients get better. So also you have to keep in mind there are infections that can lead to dementia, anxiety, depression. And I have patients who, don't need an antidepressant anymore because I treated them like they had a virus rather than giving them an SSRI.
Hmm.
And
Yeah.
same thing with anxiety.
I got you. And would it also apply to panic attacks? I mean, once again, I've been told, that people can be driving down the road and all of a sudden a wave of panic come. In
Mhm.
fact, Doc, someone I've heard about who was driving his car, got onto a bridge and had to pull over because he couldn't drive anymore. Where is that coming from?
Yeah, so panic attack is, a flood of adrenaline that's been set off by, essentially the thinking part of your brain. And so one of the things to keep in mind is that the deep reptilian part of our brain, think about a lizard sitting on a rock. They take off running if they hear something, feel something, they see a bit of movement, they're moving. And
Yeah.
that emergency system, we still have that.
Mm,
It's in the colliculi, and it basically is our early warning system. Now, the problem is the cortex feeds down to the colliculi. And so what we're thinking can set off an alarm in the emergency system.
uh-huh.
This is where EMDR actually works. EMDR is that eye movement
Yeah.
technique. It's not driving the dream machine backwards as they originally hypothesized. What it's doing, in my opinion, and many agree with me, is that it's settling down the emergency system in your brain so that you don't respond like, the abuse is happening right now or the car accident's happening right now. You respond, you know, with one step removed from it. This
Right.
is also why therapies like ketamine assisted therapy and MDMA assisted therapy work. They allow the person to step back one or two steps from the experience and examine it without the emotional overwhelming valence.
Right. I want to stay with the problem a little longer, and I
Mhm.
want to get into some of these solutions, especially the kinds of things that you're doing just blow my mind. But, what about today in this 2024, we'll be having this conversation so everyone will know. I mean, the research into childhood trauma, complex trauma is just off the chain. What is trauma, in particular, childhood trauma?
Well, yeah, Bessel van der Kolk's written whole books on this,
Yeah.
and so has Bruce Perry. So depending on when the trauma starts, it does interrupt the normal neurodevelopment of the brain. So if it's super young childhood trauma, then the normal development of the brainstem circuits and the brainstem centers that help regulate your body don't happen. And so then, you're an adult and somebody cuts you off on the freeway, your brainstem just goes kaboom, and you're in a full rage rather than to have, flip them off and go on and have the rest of your day and not worry about it. That brainstem regulation is shut down. If it happens, 7, 8 years old, then the limbic system, which is self-soothing and the ability to regulate your emotions, doesn't get fully formed. So, both Van der Kolk and Bruce Perry and others talk about that you had to go back and you had to retrain the brain
Mhm.
through these developmental steps that were skipped over, that were missed.
Mhm.
And that allows people to then really process and deal with childhood trauma.
Uh-huh.
Now, of course, traumatic memories lead to sort of that reactivation. You think about that terrible thing that happened, whether it's a car accident or a rape or child abuse, and your limbic system starts firing wildly. Your adrenaline goes up. You're already in fight or flight, or into a full panic attack. And that's where therapy that helps to disconnect that emotional tag from the experience, such as EMDR and EFT and other types of therapy modalities, and now the psychedelic assisted therapies are helping with that, is to kind of allow you to have, you're not going to get rid of the memory. You don't want amnesia, but you want to not have that emotional tag attached to the memory.
Mhm. Yeah, I'm glad you said that. Once something has happened, it can never not happen.
Mhm.
So that memory is always there. I want to put one more condition on the table, and then I want to talk with you about what can we do about them. And that
Mhm.
is ADHD,
Mhm.
attention deficit, hyperactivity disorder.
Yeah.
Okay, what is it? And yeah, tell us about that.
Well, what's interesting is that ADHD is a malfunction in the dopamine circuits, or sometimes the norepinephrine circuits that regulate the dopamine circuits in the frontal cortex. So our ability to focus lives in our frontal cortex. Our ability to put value on something and be motivated and persistent and stay on task is right above our eyes.
Mm,
And then our ability to sort of organize is back here in the dorsolateral prefrontal cortex. So different parts of the frontal cortex are involved in ADHD.
mm,
Now, one of the things that I think science really neglects is that if you take a bonk to the head and there is damage to the frontal cortex, and all of a sudden, a 20-year-old soccer player develops ADHD,
mm,
that's not ADHD, that's traumatic brain injury.
mm,
And you have to treat that like it's traumatic brain injury, not like, oh, they suddenly have ADHD, a developmental disorder. But, medicine doesn't talk about it that way.
mm,
My fellow psychiatrists say, oh, yeah, I have this patient with traumatic brain injury and they developed ADHD. Well, it's not ADHD.
mhm,
It's frontal lobe damage.
mhm.
The
Got it.
treatments, the treatments are, well, are at
Mm.
least initially different, but with the work we've been doing, theoretically, the same treatment works for either one, whether it's developmental or trauma inflicted.
Uh-huh. So let's talk about some of these treatment
Mhm.
modalities that are available today. And I want to first apply them to some common everyday mental health conditions like anxiety, panic, and depression. When someone comes to talk with you and they're clearly depressed and they experience panic and
Mhm.
anxiety, what do you do with them?
Okay. Well, I mean, I'm a very ethical person. So
Okay.
if somebody presents to me with that sort of constellation, then I'm going to say, look, we've got some options. There are these medications, and the
Mhm.
medications that I typically use for anxiety are not the SSRIs. We could have a whole hour-long discussion on just that.
Mhm.
But I talk about these are the options. And the options, are medications, and here's the main effects, side effects versus benefits. And then there's these other options that might be really interesting to you, such as what if we went in and repaired your brain so that the neurodegenerative changes that cause PTSD, that cause depression, the neurocircuitry changes that lead to increased anxiety. What if we change those?
Mhm.
And that is the infrared light therapy that
Mhm.
I talk about in my book and
Mhm.
talk about have done a lot of research on.
Okay, so your first option is it to medicate with chemical drugs, or is it something else?
I give the patient both options
Uh,
because ethically you have to. You had to
mm,
give them all the options that are available to them.
mm,
If obviously, therapy is a helpful modality. It's rule number 3 in Henderson's rules.
mm,
Medicine is not the whole answer.
right.
Pills
Uh,
don't fix everything.
uh-huh. Okay,
But
so go on, finish that
yeah,
thought, please.
so the modalities that I think that make the biggest difference are the ones that affect neuroplasticity. So imagine you have a choice between, we'll go through 20, 30 treatments with multi-watt infrared light therapy, and you're anxiety free or depression free for years. I mean, we have patients who are decades out.
Uh-huh.
Or take a pill every day.
Yeah. No, but let me help me wrap my head around this thing. So if someone had, let's say, an event, and there's some people walking around with events 30 years ago, something happened and they just can't handle it. I don't understand how laser could help correct that memory. Help me out
Yeah.
with that.
Okay, that's a great question. So we got to get back to the fundamental of what infrared light is doing.
Okay.
So first off, infrared light therapy is not one thing. It's many things. And we had to be careful about that. That's one of the main scientific treaties that I put out there, is that what we're doing with multi-watt infrared light therapy is we figured out in the laboratory how much energy I had to put on the forehead or on the scalp to get through the scalp and get through the skull and into the brain and directly treat the neurons. There's a lot of infrared light devices that are LEDs, they're half a watt, you stick them on your head. It doesn't even get through the skin. It doesn't even get beyond the skin. It goes about half a millimeter into the skin and stops. But they do something. They do a little tiny benefit. The depression studies, they got a little bit better, but as soon as they stop the treatment, they're back to baseline. The depression comes back. What we're doing with multi-watt infrared light therapy is that we're directly treating the brain, and we're creating a lasting change, years. Now, what is the infrared light doing once it gets there? Well, the infrared light activates the mitochondria, which are the little organelles that make energy. Now, of course, that makes more energy, but it also makes the mitochondria send signals to the cell. And the cell then starts producing growth factors like brain-derived neurotrophic factor, BDNF for short. BDNF drives neuroplasticity in the adult brain. So literally it drives brain healing. Now, I'll give you just one example.
Okay.
Probably one of my favorite patients. This fellow he was in the Navy. He was on a ship that was monitoring Israel during the Six-Day War. Israel took umbrage with that and came after it with PT boats and helicopters and jets, and nearly sank the ship, killed half the crew. He had a brain injury from that himself, but he's also picking up his guys and his shipmates and putting them in the freezers in the galley because there's so many dead bodies and they're in the middle of the Mediterranean. He lived with that trauma for 49 years. And then he came to our clinic and he got treated. Prior to coming in for treatment, when a jet flew over, and they fly over all the time in Denver, he'd be in the basement crying, curled up in a ball on the floor. Helicopters, same thing. Now, helicopter flies over, no big deal. Completely resolved.
That's amazing. This is really, if you've ever watched a Star Trek episode, this is really Star Trekky. So I've looked at that device that you use. It's literally a scan, apparently, of the front of your forehead, right?
Well, yeah, I mean, so it's a handheld laser, and it's powerful enough that this is not something you want to do by yourself at home. You need to be trained. This laser can hurt your eyes. And so there's a certain, you've got to keep it moving. And it will heat things up. And that's one of the things that we're studying in the laboratory is what is that rate of movement to keep, the brain from cooking. Cooking the brain is a bad outcome.
Yeah, I mean, look, this is just the technology today is amazing. I had a torn retina, and I went to my ophthalmologist, and he actually pulled out a laser, and I saw the beam of laser as it went into my eye, and he corrected it in seconds. It's just amazing what medicine is able to do today. So Okay, so if a person, let's talk about more severe conditions. You've mentioned one, that veteran, and I've talked to a lot of veterans.
Mhm.
Some of them are still dealing with Vietnam. They
Yeah.
can't sleep, stuff. Others, Gulf War, they can't
Mhm.
sleep. It's just difficult. Can you help someone like that who has who had an IED experience, for example, and still dealing with the effects of
Mhm.
that?
Yeah, that's a really important area, and it's something that I am passionate about.
Mm,
We, in fact, have a foundation, the Neuro-Laser Foundation, and it provides subsidies for veterans and first responders to
mm,
get treated. Now, that's how that one veteran came to our clinic is, we said, look, we'll take care of 50% of the costs. Um, the another veteran who he's a wonderful young man. This man immigrated from Syria to the
mm.
United States, became a citizen, signed up with the Marines, and went back to fight in Syria.
Wow.
I mean, that's an amazing young man. But, the trauma of that, of the combat was very clear for him. And, with infrared light therapy, he got better. He's now moving into the intelligence side of things, which is, I think, a brilliant move on his part.
Mhm.
Now, IEDs. So our first study that we published in 2015, our first 10 patients with traumatic brain injury. Several of them were veterans who had been exposed to IEDs. One had gone through 8 explosions.
Mm,
He was actually in charge of disarming the darn things. And, obviously, you're not always 100% successful. And he had 8 explosions. He was literally on the verge of losing his family. He couldn't hold a job. He was irritable. He was angry. He was fighting with his wife. They're on the verge of divorce. After treatment, he's calm. He no longer has nightmares. He's sleeping through the night. Headaches are gone. Depression is gone. Anxiety is gone. He gets a job. He's still working at a local brewery here, retrained and doing his thing. Another veteran is making his own guns.
mm.
They're beautifully hand carved, handcrafted, um, um, really works of art.
Yeah. And that's just amazing. Because the thing that I'm still want to clarify in my own mind is that some people just deal with recurring thoughts that they know that nothing is happening now,
Mhm.
but the thinking pattern goes back to something early on. And you're saying that the laser may help disrupt that?
Mhm. Yeah, absolutely. Yes.
Uh-huh.
Yeah, that's what we're saying.
Uh-huh. Okay.
Uh,
All right. So when a person is struggling with something today, there's several options, and you've already talked about them. One is they can take the pill. That's one possible option. But there's another option that's very popular today, which is cognitive behavioral therapy.
mhm, mhm,
So when you're weighing all of these options, let's say just an ordinary patient, he doesn't know anything about anything. How do they figure this out? Should I take the pill? Should I do psychotherapy? Or should I do something more novel, like laser?
Well, the my advice to a patient is that therapy is always an important piece of this process.
Mhm.
The hard part, if we go back to veterans, is that that's all they get. They get, cognitive behavioral therapy. They might get put on an antipsychotic, and antipsychotics are bad for your brain.
Mm,
That's been shown in animal studies. And they might get put on an SSRI, and SSRIs work in PTSD about 20% of the time. So you got a 1 in 5 chance that you're going to get better. And I don't like those odds. We're losing too many veterans, and we've been
mm,
losing veterans, for the past 15 years at about the same rate.
mm,
Every day, 11 veterans die.
mhm. Okay.
Depending
Mhm.
on your statistics, some say 21. I mean,
Mm.
that's a lot
Yeah.
of people.
That is a lot of people for sure. Yeah. So, in terms of drugs, medication, I've been hearing, and I know you've talked about ketamine as
Mhm.
well. So, if you were picking a medication to treat someone with depression, anxiety because of the PTSD or whatever, would ketamine rank higher than some of the others, or are they equal in your judgment?
Okay, so one of the beautiful things about ketamine is that it turns on that same neuroplasticity by a different mechanism. It raises BDNF levels and it raises the receptors for BDNF. So there's more stuff and more receptors for the stuff. So there's more neuroplasticity action. Ketamine works over a period of time, as any neuroplasticity does. So one of the things that's important about ketamine is that, in my opinion, most clinics don't do it correctly.
Mm.
They say you got to get 6 infusions in 2 weeks. Well, an axon grows a millimeter a day. Neuroplasticity is not going to happen in 2 weeks. It takes a couple of months. So when I first understood what ketamine did, that is, it turns on neuroplasticity, when I opened my first clinic 11 years ago, I said that, we're not going to do it that way. We're going to give 1 infusion a week, maybe 1 infusion every 2 weeks. And what we see is that our response rate is 72%. The national average response rate of these other clinics is in the 50s. Mm. And our patients, on average, get 4.3 infusions in their lifetime. Mm. Well, at the other clinics, you're guaranteed to get 6, and then probably boosters, right? 6, oh, you need another 2, 3, and you're 8 infusions in, and you still have a 50% response rate. Mm-hmm. So, and let alone the fact that a lot of clinics believe that you had to make somebody hallucinate in order to help their depression. Mm. Now, we have a 72% response rate, 72, 73, depending on the year. And in all those years, 1 person has hallucinated on ketamine in my clinic. Okay. You don't need to do that to turn on neuroplasticity to fix depression. So let's go back to that original question that you asked, which was, how do you rank that? How do you create that hierarchy? So let's take an imaginary patient who comes into me. They've had depression for 20 years. They've failed 3, 4 SSRIs and maybe, Effexor and SNRI, maybe Wellbutrin, a dopamine norepinephrine reuptake inhibitor. So they've tried all the different neurotransmitter combinations. What's the chance that giving them something else that works on the neurotransmitters is going to make a difference? Very, very small. So it's time to talk about what their other options are. Right. So obviously ECT, electroconvulsive therapy, shock therapy. Still, I mean, if you're ever on Jeopardy and they ask you, what's the best treatment for depression, the answer is electroshock therapy. Well, actually, it's what is electroshock therapy. But, who wants to do that? And it's hard on your brain. It causes memory problems often, et cetera, et cetera. There's vagus nerve stimulation. They go in and they stick a little electric box in your chest and a wire to your vagus nerve, and it might cure your depression, but that's an invasive procedure. There's, ketamine infusion therapy. Again, you get a 73% chance that you'll get better. And stay better for years. In my book, I describe many of my patients who are 8, 9, now 11 years out, and they're not depressed. Now, are they not on medicines? No, they're probably still on a small dose of some medicine, but they're not depressed. They're living a life of joy and peace.
Right. Can't beat that. Life of joy and peace.
There you go. Yeah.
So look,
patients who hang on. So patients who get laser therapy, in our study, there was a 95% response rate. 95%. Okay. And they stayed undepressed for years after 20 treatments.
And that's
that's an investment of $6,000, and you don't take a pill, and you're not depressed, and you're joyful and at peace. That's a good trade-off.
That's good news for sure. Yeah. So, but let's go back to ketamine for a moment. Yeah. You mentioned hallucinations as one side effect, but you're saying it doesn't happen very often. What are some other side effects of ketamine?
Well, let's clarify the hallucination piece, because it can happen a lot if your dose is too high. So a lot of clinics purposely ratchet the dose up and tell people hallucinate because they believe and it's not true, that you must hallucinate to cure depression. And it's not true. So at half a milligram per kilogram, nobody's going to hallucinate. At 0.7, nobody's going to hallucinate. You get up to 1.5, 2 milligrams per kilogram, people are going to hallucinate. And that's not good, and it's not helpful. Other side effects with ketamine, again, are dose dependent, but even at the low dose of half a milligram per kilogram, a lot of patients will get sort of the spins. It's sort of more like you're on the ocean. So they get sort of this vertiginous nausea or kind of motion sickness. Now you can prevent that with, pre-treating with, Versed, or not Versed, excuse me, strike that, Zofran on Dancitron. Some people don't like the feeling of being out of control. And so, sometimes we'll, give them a little bit of Versed to calm that so they're not getting upset. Ketamine can theoretically increase your blood pressure. That's one of the reasons it's used so much in pediatric hospitals, is that ketamine doesn't suppress respiratory drive, and it doesn't drop blood pressure. And those are two really common things that other anesthetics do. So ketamine can increase blood pressure. If your blood pressure is a little high coming in, then very likely your blood pressure could go up, and that can go up to dangerous levels, which may need intervention or just plain stopping the ketamine infusion. Those are the main side effects.
Okay. Now, you mentioned that some, clinics may use ketamine to induce hallucinations. Is that the same type of effect that psychedelics, people who use psychedelics, try to induce in a person to overcome depression, anxiety?
Not really. So, ketamine assisted psychotherapy, for example, you need to be at low doses because the patient has to kind of still be in the room, right? They can't be off in la la land because you're trying to do talk therapy while they're on ketamine. Now, I've done this with some very, very severe trauma cases. Probably the most severe trauma I've ever encountered in my entire professional career. And so I brought her psychologist in, and he did a combination of EMDR and psychotherapy during a ketamine infusion. Now, we kept the dose really low so that she was, able to participate. But what ketamine does, it's a dissociative anesthetic. So basically, it allows you to take a few steps away from yourself. Okay. And that allows you to see things. So literally in the middle of this therapy session, she's talking about, they're talking about the trauma that she experienced. And she gets this look on her face and her eyes get big. And she says, "You mean it wasn't my fault?" And we're talking about abuse of a child. And abusers do that. They beat into their heads that it's your fault. "Oh, you made me do this." And she suddenly realized, oh my God, it's not my fault. I didn't cause this to happen. So MDMA works on serotonin. It increases serotonin levels and creates sort of this euphoric, peaceful, lovey-dovey state. That's why it's a great, rave drug. But MDMA-assisted psychotherapy allows, again, this sort of not stepping away from yourself, but able to strip away the self-criticism and the guilt and the shame that drives that self-hatred, and allows you to love yourself a little bit. And so, MDMA assisted therapy for cancer patients who are dying allowed them to come to peace with death. That's amazing. And they lived their last few months of their life with peace and joy, rather than terror of, oh my God, I'm going to die. That, yeah, I'm going to die. And here's the rest of my life. Let me enjoy it.
No, that's once again, that's good news. Just so people will know, all of these conditions we've talked about, anxiety, depression, panic, trauma, you think that there is a way for people to resolve the things that cause them emotional pain, pain.
Absolutely. And the thing that I would impress upon your listeners and viewers is that don't settle for being a little bit better. You know, if you're depressed and now you're okay, and I'm not crying all the time and laying in bed all the time. I'm functioning, but I'm not living a life of joy and peace.
Mm.
Then don't settle for that. That is
Uh,
not treated depression.
yeah. When you say live a life of joy and peace, it sounds like you're one of these people who live that life. So you think that it is possible for a person to actually live a life of joy and peace, regardless of what's in their rearview mirror.
Yes, I do. And I just had this conversation with a patient yesterday, a new patient who's coming to me with a childhood abuse history. I talked about the idea that treatment is like peeling an onion.
Mhm.
There are layers. So you'll take care of the first few layers, but when in her case, when her daughter got to be the age when she was abused, when her daughter got to be 8 years old, a whole new wave of trauma hit her.
Mm.
And when her, daughter had her first baby, a whole new layer of trauma hit her because it's nested inside, and we deal with these layers at a time. So for everybody who has trauma, for everybody who suffered a loss, there are these anniversaries, and there are these layers, and we had to keep addressing them. So to say, yeah, it's a one-time fix and everything's hunky-dory is simplistic.
I understand. Yeah. So it's a lot like if you're eating health clean today, you're doing pretty well, but a year from now you're eating dirty. You got to go back to eating clean, something
There
like
you
that.
go.
Yeah.
Yeah.
Okay. So you founded Neuro-Luminance, your company. Tell us about Neuro-Luminance and what you try to do, what you do there.
All right. So Neuro-Luminance is focused on the two modalities that we have available that increase neuroplasticity,
Mhm.
ketamine infusion therapy and the multi-watt infrared light therapy. And one of the areas that I think we haven't touched on, which is really important to, the country and the world, is long COVID.
Yeah.
So COVID was this infection that set off this huge inflammatory response. And some people after COVID is gone, the infection's gone, the inflammation is still there in their brain,
Mm.
or also the inflammation activated viruses or other types of infections that were hanging out in your brain. And so that leads to long COVID. And so what we started treating long COVID patients, and many of them had tried all sorts of things, ozone, hyperbarics, vitamin C infusions, and they weren't getting any better. And they came and got infrared light therapy, and they're remarkably better. On our website, there's actually a couple of testimonial videos by a dentist out of Florida.
Mm.
And this guy, not only he was fatigued, he couldn't think, he had a tremor. And a tremor in a dentist is not a good thing.
Mhm.
And he came and got treated. His tremor went away. His brain fog went away. His memory problems went away. His energy came back. And then he pulls me aside around treatment 15 and he says, Doc, this is the weirdest thing. Um, I've taken I've taken stimulant my whole life, and I take my Vyvanse now and it makes me jittery. So I stopped taking my Vyvanse and I can concentrate just fine.
Wow.
And so in fact, he went home. He his ADHD is gone. His anxiety is gone. He doesn't have to take a benzo to go to sleep at night. He doesn't
Mm.
need to take a stimulant, Vyvanse in his case, to function during the day.
Mm.
It's gone. And so we've treated a bunch of ADHD patients since then and seen very similar results. Patients with severe ADHD, probably related to brain injury,
Mm.
are on much smaller doses, and some patients are not taking a stimulant at all.
Mm.
So long COVID, uh, we're working on the inflammation piece, but also I pay attention to those potentially reactivated
Mm.
viruses and other infections. And that's a really important unaddressed area in sort of national NIH-driven medicine looking at long COVID is the
Mm.
importance of these reactivated viruses.
Mm-hmm. That's glad you said that. You mentioned COVID. Is there any way we can protect ourselves from COVID? What's the best thing we can do to help
Mm.
ourselves?
Well, it's an unpopular answer, but wear a mask.
Wear a mask. Okay.
Yeah, I mean,
Very
it's a respiratory infection.
okay.
Obviously, get your vitamin D levels up. If your vitamin D levels are high enough, it makes it harder for the virus to bind to the receptor that it binds to,
Hmm.
the angiotensin 2 receptor.
Okay.
So vitamin D helps. I have lots of patients who are on vitamin D, and we're shooting for levels of 70 to 100. And most doctors say, oh, well, if you're at 40, you're fine. Well, no, not if you're trying to prevent getting COVID.
Hmm.
And wear a mask. It's a respiratory virus. And I have fought back against the anti-maskers, and their claims that, oh, it causes hypoxia, and that's all nonsense.
Hmm. Well, are you a big fan of getting the stick, the vaccine?
I missed that. Can you say that
Yeah.
again?
Are you a big fan of getting the vaccine?
I think it is, every vaccine has pluses and minuses. Even the best of our vaccines have, potential side effects. Every medicine has potential side effects. The vaccines were the right move at that time.
Hmm.
Now, the trick is just like look at influenza. The influenza vaccines are created in April, trying to anticipate what's going to happen in November. So way back here in April, we're trying to figure out what's going to happen up here in November. Sometimes they get it right. 50% of the time they get it wrong. So vaccines are a tricky thing. If we don't want to go down the whole anti-vax
Oh yeah.
rabbit hole. I'll say one thing though. And one of the areas that I work in is autism, and I'm a medical advisor to the U.S. Autism Association.
Mm-hmm.
And if you look at other countries like Iceland, where vaccination is mandatory, the rate of autism is 1,000 times lower in Iceland than it is here.
Wow. Hmm.
In Cuba, the rate of autism is almost 100,000 times lower. And Cubans get a whole lot more vaccines than we do because they're down there where all these other infections are, right? How is that? How does that make any sense? If a vaccination causes autism,
Hmm.
that doesn't make any sense. So here's the answer. You know what Iceland and Cuba don't have? Tylenol.
Ah.
So look into this. Robert Shaw, who used to head Great Plains Labs, looked at this across thousands of cases. And Tylenol is a neurotoxin. And giving kids Tylenol when they get a vaccine is basically again, okay, we're going to give you a vaccine and we're going to give you a neurotoxin. You get to decide which one you blame.
Mm.
Now,
Yeah.
I'm not saying that the getting a vaccination does not cause autism. I'm not saying that because I have patients who will show me the video 5 days before the vaccination, 5 days after, or a week after, and it's a changed kid.
Mm.
They have autistic features, but that is not necessarily because of the vaccine. It is likely, based on looking at things like Iceland and Cuba and other data, that it's really about the Tylenol.
Hmm. Okay.
All right. So sorry for that little. I
No.
mean, in April, we're going to be in the middle of this.
Yeah.
By the time this podcast comes out, we are
Uh-huh.
going to be in the middle of that debate.
Yeah, I got you. Well, I think it was a pneumonia vaccine I took some years ago. It almost killed me. My
Hmm.
doctor said, "Look, you must be allergic to it." So I don't know. But
Mhm.
anyway, one last question for you. I love the title of your book, "Brighter Days Ahead." Why did you write this book, and what did you put in it that you want your readers to get?
Yeah. So I found myself over 7 years at that point saying the same thing to patients over and over again. Um, and getting stories from patients who've gone to other clinics about how badly their ketamine experience had been botched. And I just felt it was important to start to really educate people about one, how ketamine should work and how it does work in the brain, and how infusion should be done and what to expect from it. You know, the internet played it up and it was, oh, you know, you get this infusion and the next day you feel wonderful and all is better for the rest of your life. Well, no, the chance of that happening is about 25%. So giving people realistic expectations about what ketamine could do. Now, of course, so writing the book, you know, I really had a chance to think about what I want people to think about depression and rethinking this whole chemical imbalance theory and thinking more about neurodegeneration and neuroplasticity as the important pieces in treating depression, PTSD, and other brain disorders.
Okay. Well, look, I love it. And I'm so glad you're doing what you're doing. So thank you so much for spending time with me today.
I was very happy to. Great questions. Great
Okay.
questions.
Well, you've been listening to the Possibility Action Network podcast. Our guest today has been Dr. Theodore Henderson, a psychiatrist and the author of Brighter Days Ahead. I'm your host, Stephen Middleton. Until next time, good day.
You are not alone. Just keep on, keep on, keep on going. Just press on, press on.